We are the ones that are going to shape the ultimate product that comes out of the deliberations of 3 full committees and 2 Senate committees working toward a health reform piece of legislation that will go back to the White House.
First of all, I used to run prisons. I was a prison guard, and I ran prisons, and I was responsible for them for about 25 years. And I know a screwed up system when I see one. The second part of my life was running a pretty large company that had run into serious trouble, and I was fortunate and lucky to bring it through a bankruptcy. Out of that process, I learned how to count. And I know what costs can do to anything in front of us if they're not controlled. Perfect for healthcare thinking. My last assignment was as Secretary of Human Services for both Republican and Democratic governors, including Howard Dean up in Vermont. And there I learned about what the people are going through and the desperation that a lot of them are feeling on a day-to-day basis. Most recently, the last 10 years, I've been working primarily in Europe. And I've had a chance to see the healthcare systems in Norway and France and the UK and Northern Ireland and Scotland and currently the Netherlands. We are so far behind, it's disgraceful. Just a couple key points here. This issue is about cost. It's about runaway costs. If we don't handle these costs in whatever is going to happen on the great health care reform front, if we don't deal with these costs, anything we do is doomed. It's having an unbelievable impact on every possible part of our society. It's like a cancer that's metastasized throughout society at this point. You know, I could tell you a little bit about Vermont history, but I'm not going to. At one point, we had a chance to be one of the original 13 colonies, but we decided to sit back and watch how it would turn out for a while. And during that period, we were actually a republic for 13 years, and we decided to try to annex Canada. Didn't work out so well. But back to cost. What it's doing to our families, it's so well documented. Vermont is a low-wage state relatively. I mean, for half of our population now, it's 25% of their income. And the premiums are going up 11, 13, 14% a year. It's having a devastating impact on families. We have people getting divorced in order to get health care. And getting married in order to have health care. Well, maybe they offset each other. As a businessman, though, I mean, I could tell you the battles that we fought just to try to stay in balance. There is no question in my mind that we are becoming increasingly uncompetitive because of the extra costs of health care, whether it's on the shelf, whether it's the extra cost of cars, from your neck of the woods. It's no secret why people like IBM and others locate big facilities in places like Ireland and France, because they figured out how to do this. This has turned into a very, very serious economic and competitive problem. For our communities and states, it's driving our property taxes through the roof. And that is now beginning to attract a whole different kind of people interested in this subject. School taxes are going up. In my little town, the school taxes went up only because of the increase of healthcare costs last year. That was the only reason they went up. Put yourself in the shoes of a hard-working Vermonter who is working for a small company who doesn't have health care and who's paying out taxes for the teachers that are paid for by taxpayers. I got nothing against the teachers. I'm glad they've got that health care. But just think about the social tension and distensions that begin to occur when you have a system like ours. Massachusetts, frankly, if it's not on life support today, it will be tomorrow. The large companies last year, in 1 year, their premiums went up 24.6%. They are in some serious trouble on this one. And if it wasn't for the largesse of our federal government, they'd be out of business now. It would be moribund. Hospitals and docs. Half the hospitals in this country are now losing money. Vermont has a wonderful history of small community hospitals spread throughout our entire little state of, I hate to say it in this big place here, but 640,000 people, that's all we are. But we've got 11 hospitals, small, beautiful, community-oriented hospitals. They're starting to go broke, and they are very important to our communities. They organize a lot more things than just healthcare in our communities. Hospitals in some parts of the country now are in absolutely tongue wars with each other, fighting for patients. I've got a clipping on right in front of me over there, and it's about 2 hospitals in southern New Jersey. I was just sharing this with Mr. Lighty, and he couldn't believe it. They're fighting over heart patients. If one of them gets them, they don't want them to go to the other hospital. There's a story in the Philadelphia Inquirer from last week that basically paints the image of a hospital not giving a heart patient a wheelchair to get out of their hospital. And the family had to come in and pick them up and carry them to the other hospital. This is getting crazy. Our economy, the biggest sense, it's hurting our international competitiveness in a very serious way. I got a quick story I got to tell you. I was in a hospital in Northern Ireland 3 years ago. Had a blood infection, out of the blue. My wife was with me. I spent 3 days in the hospital in Antrim, which is about a catchment area of about 250,000 people. And at the end of that 3 days, it came time for me to settle up the bill. So, I've got the stateside insurance. I knew that my insurance company would take care of it. So I asked for the controller. And, they didn't quite know what that was. So then I asked, well, who do you pay the bills to? Oh, he said, no, our government pays your bill. He said, but I'm from the States. I've got means. I can pay for this. My insurance covers it. And finally, working my way up the bureaucratic ladder in the hospital, I got to a guy who seemed to know what he was doing. And he said, Mr. Hogan, you don't understand. It's not worth it to us to set up a billing system just for you. Now, if that doesn't capture the contrast in terms of the crazy overhead that we have built into this system and the numbers, I am a fan of Himmelstein's and the homework that this guy has done. It's been quite phenomenal. When you reach the point where you're paying 30 cents on every dollar for paperwork and administrative costs, you're out of control. And that is really a very key part of our lack of competitiveness. Last thought about Little Vermont. Prior to 2005, when Vermont instituted 2 things called, one was Catamount Care, which was frankly subsidized care, and chronic disease management. Both good ideas, both good stuff. And in fact, our uninsured numbers got a little better. But so did they in Tennessee when they tried it. And so did they in Maine when they tried it. And so did they in Oregon when they tried it. They get a little better, but then the price catches up. And government cannot catch up with the cost of this monster that we've created. I'm awful glad for those 6,500 people or how many have gotten the new Catamount coverage. I'm glad for them. But it didn't do a damn thing for all the other citizens that are paying unbelievable prices for their health care now, which is only going to increase the uninsured, sure as death and taxes, very quickly. In the meantime, our costs over the last 2 years since we've implemented our program have gone up 19% in total. So, chronic disease management, good idea if you want to talk about quality. But there's no evidence out there at all that says it's going to save any cost. But yet the politicians are selling this on the basis, well, we're going to save costs. You know, to really make chronic disease management care work, it's going to take a cultural change. Cultural changes take time. They take time. By the time, if we were totally successful in implementing our disease management, our chronic disease management, and I like the idea, healthcare costs will have doubled again. Just think about where we're going to be. So, in sum, making progress on healthcare is all about controlling costs. You can't get away from it. With controlled costs, access to care and quality, we can make those kinds of improvements. But please ponder this question as you in your own ways interact with this whole reform process. Do any of the proposals that you have seen or are under development deal strongly, openly, concretely, and in a timely manner with the cost of health care? Do the untested theories of chronic disease management as it relates to cost, public option as it relates to cost variances as it relates to cost, or pay for performance meet this test? Will they reduce cost in a major way? At this point, we need more than hope and speculation. The primary way we can pay for healthcare reform is by spending less, by wasting less. Thank you very much.
First, these are important if we're going to understand health policy. All of us are not alike. We all pretty much eat roughly the same amount of food, roughly. But in healthcare, most of us are healthy. Few are using most of the healthcare. That's a very important concept, especially when you're figuring out how to pay for it. Secondly, the supply of what we have, that means hospitals, doctors, etc., drives most of the cost. And I'll talk about that. Most of the costs in healthcare are fixed. That is, once these services are in place, really, they're going to continue to perpetuate because most of the costs are there whether a patient's in the bed or not. Fourth, we're already paying the whole bill. We just don't know it. It's really the truth. We are unaware that we Americans are paying the entire healthcare bill. And five, we really don't have a healthcare system. We keep talking about one, we don't have one. Every other industrialized country has one, but we don't. So what are the costs? The first image that comes to mind when you ask people this, and I do a lot of public forums, et cetera. We had one last night in Middlebury, but you know, around single payer. By the way, 150 people showed up, this little tiny town in Vermont. But what are the costs? A lot of people get this image of it's those fat smokers going into McDonald's. That's what it is, and if we have more than our share in this country, et cetera, and that's what the costs are all about. And as I said before, if you look, most 80% of the population uses very little care. They use about 20% of the care. But the other side of it is 20% use 80% of the care. Now, one possible solution I would offer to you, this could save a lot of money, is just get rid of the sick people. We'd only be spending then 20% of what we're currently spending. What, you know, it's not bad. But really, any of us could be in that group at one or many points in our lives, right? You're born, maybe you're a premature baby, and then you're fine again, and you're back in this group, and then you're back there, you had a skiing accident, and then you're back here again, and then, you know, you get old, and you're back in the nursing home, and you're in that group again. And when you are in that group, what are you expecting? You're expecting that to be there for you. This medical, basically healthcare infrastructure, are the fixed costs that I'm talking about. Now, there's millions of jobs, high-skilled labor, etc., and that is what most of the costs are about. 70% of our healthcare dollar is spent on this infrastructure. As I said, mostly fixed costs. So you're not paying for Joe, you're paying for a nurse. You're paying for an ER, an ICU, a burn unit. These are the things we have to consider, because even if you're selfish about this, you better be worried that if they didn't pay for the ICU bed the day before you got there, it may not be there for you. So even from the selfish perspective, let's look at it this way. Let's turn it on its head and ask ourselves how we should pay for this. So the implications of fixed costs are this. The cost of the infrastructure, as I said, is there whether it's being used or not. The nurse is there before you get there, and if you have a payment attached to you, fine, but if not, what are you going to do? And trying to save money, as managed care used to do by keeping patients out of these beds, is like trying to save money on schools by keeping kids home for the day. Right? It's really the same thing. It just doesn't amount to that the way we pay for it. So it seems much more wise for us to invest as a society in only what we need, because these costs are there. And as we've seen, when you have too much of expensive infrastructure, MRI scanners, expensive hospitals that aren't needed, competing cardiac hospitals right across the street, you're paying for them one way or another anyway. So I'd ask you to ask yourself, whose responsibility should it be to pay for healthcare services that you expect to be there? They're not used by very many people. Take a burn unit, very few people in any one year. Do you expect a burn unit to be there for you? Do you expect an ICU, intensive care unit? Very expensive and very poorly reimbursed. Yes. You expect that? Do you expect the ER? Yes, you do. All of us expect this stuff to be there. And if we don't find a way to pay for it, very expensive, 20% using it at any one time. We've already figured this out when it comes to the fire department, haven't we? The police department. Why is it we say something different when it comes to healthcare services that we expect? Just the selfish part of us. We've got to figure out a way to finance it. Well, how do we pay for care? Well, we really don't have a healthcare policy. That's why all of us are sitting here. Because people are entering hospitals getting care or not getting care. And we finance these services on a wing and a prayer. A hospital, they do this kind of behavior of saying, putting patients in the beds when they don't need to be. When you have too many doctors who don't have enough to do, we're a hammer, you're a nail, okay? Coronary bypass, unnecessary procedures, etc. So, financing of healthcare then really amounts to a shell game. Who wants to pay? What payer wants to pay these fixed costs? Who wants a patient with end-stage diabetes? What insurer really wants them? So it's really a shell game of shifting these costs from one payer to another. And then the services have to fight with these payers to keep their doors open because they need to pay their fixed costs. So these are all the things we have to consider. But it's a great jobs program for the administrators. In fact, we've seen more than a 3,000% increase in the number of administrators since 1970. And at the same time, only a 159% increase in the number of doctors and nurses, actually. So that's actually where the jobs are, in this administration. And that's why we're having some of these political conversations. But when all is said and done, 31% of the healthcare dollar is spent on administrative costs. So that's the payer administrative costs. You funnel this money through all these different payers. And then on the provider end, we have to keep our doors open. Everyone has different insurance. We have to hire all kinds of administrators. 31%, completely wasteful. If we have a rational system, we can do something about that. Who's the ultimate payer of healthcare? You just don't know it, but it's you. You're paying taxes for Medicare and Medicaid, you're paying out-of-pocket costs, you're paying property taxes to pay for public employees' health insurance, you're paying higher prices for goods, for your cars, to pay for, if your private employer pays for your health insurance, you're getting lower wages, etc. We're paying the entire health care bill, not insurance companies, us. And what is happening? 42% of people have either under insurance? Something's wrong. 60% is financed by the taxpayer. When you add Medicare and Medicaid, public employees' health insurance, and the tax subsidy that employers get. So, I'm not going to go through these except to say, do we really have the best healthcare system in the world? You've all heard this, I think, through all the hearings that you've been to recently, that no, we spend twice as much, we don't live as long, more babies die in the first year of life. We see the doctor less often, we're hospitalized for fewer days. We have fewer nurses at the bedside. Again, you can look these up. I can give them to you if you'd like. Fewer hip replacements. We actually do more heart transplants. So other industrialized countries have expensive technology. They have similar demographics. Their population is aging. They have rising drug costs. They have similar levels of service. Why are their costs so much lower? Well, they have uniform, universal, comprehensive benefit packages for all of their people, whether they're single payer or multiple payer. They have uniform rates of reimbursement, etc. So that creates less administrative. It's basically, they're more administratively simple. They have more primary care and prevention, and they do health planning. More assess what the needs of the population. They don't have two competing cardiology hospitals, and that causing the infrastructure costs that go along with that. And they have some sort of a budget mechanism. There's different types of systems I'm not going to go into, but all of these countries have these fundamental features. Everyone is included. Not only because it's the right thing to do, because they feel the moral imperative, but because it's administratively much simpler to keep people in than to keep them out. It takes a whole lot of administrative waste and bureaucracy to keep people out of these empty hospital beds that we have on occasion. Public financing, spreading the cost across the whole population. How else are you going to pay for a burn unit? There's really no other way. Essentially what I'm describing is a public good. We need public accountability, though. When things go wrong, I always say a healthcare system is really like a good marriage. No one expects it to be free of problems, but you at least have a way of solving those problems. And that's probably a really good definition. We are not expecting this is going to be always good and everybody's going to always be happy, but you have a way of solving problems through a public accountability process, a public oversight that we need to do health planning, etc., and a budget process. All of these things other countries do, and that is the reason that they spend less than we do. So essentially, healthcare is an investment, regarded as a public good, where you have the services needed for the whole population. You collect the money through taxes of one form or another, and you pay for care directly. I, again, would ask you to look at the quality, affordable healthcare for all goal that President Obama gave us. Why are we talking about all these other options when we have all of this evidence that single payer, which would be the one I am in favor of, I'm very biased, but again, many countries have single payer systems, and essentially you collect the money for healthcare, put it in a fund, and pay for healthcare directly. That's a single payer system. Everyone's in, you get a card, doctor of your choice, private healthcare. So it's a public-private partnership, right? Public payment and private healthcare. So you can choose who you want, the doctor or hospital of your choice. If we had such a system, current spending levels would be more than enough to pay for every single thing that you could possibly need, with no shortages that you hear about in Canada and some of the other countries. Twice as much money, but spent differently. More spent on medical care, less on administration. That's essentially it. This is basically a possible funding mechanism. The money that's currently for Medicare and Medicaid, we could fund it this way. We could have taxes coming from, again, this is the question. Not whether we should do it. Healthcare should be a public good. We have to figure out what taxes are fair to pay for that public good. And that really should be what we should be debating here in Washington. Not whether we should do it this way or not. But that should be the discussion. Maybe some of these taxes don't seem fair. That really should be where the argument is. Put it in the fund and pay for health care directly. Well, what about the public option? I'm only going to give, most of you know about the public option, essentially a plan that would compete with Medicare, keeping all the other, if you like your health insurance, you get to keep it. Last night, as I said, it was in Middlebury, Vermont. And we actually had a meeting. It was called Single Payer, How Do We Get There in the state? So we're actually pushing, if you guys don't get it done here, we want to have it be able to do it in the state of Vermont. So a doctor showed, actually a dozen doctors showed up, and one doctor was a pediatrician. He was in an office of 3 pediatricians. Little tiny Middlebury. And he actually showed us the billing that he has to do for his little tiny office.
And the arguments we often hear, I mean, you all are steeped in this every day, are essentially political feasibility arguments. And so I was reminded by our legislative and political director here that we do have a single payer. It's just for AIG and Citibank and Bank of America. Right. So I guess what we're talking about, Chairman Conyers, is the rest of us, right? What I wanted to talk about was a couple things. Essentially, how we can understand single payer as a fiscally conservative approach to healthcare reform. Because the definition of fiscal conservative, of course, is that you pay for what you do and you get maximum value for the dollar you spend, right? And anyone who wants to make the case that the current system is fiscally conservative, I think would have a very difficult time. Because we are certainly not getting the value for the dollar. We're getting 69 cents of that dollar when it comes to patient care. And we are not controlling costs in any kind of way that enables us to actually pay for what we need, as Dr. Richter has pointed out. So by definition, our current system and a system based upon private insurance and multi-payers, as it's, I think, currently being outlined in many of the proposals, cannot be considered fiscally conservative. The reason that we know that single-payer mechanisms work is because those countries that have them have better health outcomes. That they do have lower infant mortality rates, they live longer, and they have greater access to primary and prevention care, and they have better access to disease management. We had a number of studies, of course. One of that Jerry Jenkins, or one of our co-presidents, cited in her testimony this morning was that if we just had the same level of timely and effective care that France, Japan, and Australia have, we'd say fewer, that is to say 100,000 fewer Americans would die, just if we met those standards in those countries, France, Japan, and Australia. Obviously, the U.S. fares the worst in out-of-pocket costs and the number of chronically ill adults who forego needed care because of cost. And that's where the chronic treatment does impact, spending, of course, because the fact that chronically ill adults are not accessing care means they're ending up in the ICU, essentially, and much more expensively. But specifically on the insurance companies, I think we have to understand this from the fiscally conservative point of view, because it's the waste, fraud, and abuse of those companies that is causing us to waste so much money. The AMA showed in its report card at its annual meeting last year that doctors spend 14% on administration just to get paid. So that printout, right, that Dr. Richter just showed, 14% in a typical doctor's practice is spent trying to collect money from those folks. It's unbelievable. Then we look at the specific insurers. United Health is my favorite. United Health had the lowest rate of contract compliance. They're not even paying what they told the doctors they would pay. Except it's 62% of the case they actually fulfill their contract, right? And then they have the audacity in Oakland, California, to cancel their contract with Children's Hospital. So any resident of Oakland or the Bay Area can't go to Children's Hospital if you have United Health. It's extraordinary. It was amazing because this AMA spokesperson concluded that there's no question that administrative costs for doctors and the country would be a lot lower in a single-payer system. United Health made $953 million in the first quarter of this year. It's a recession. They made nearly $1 billion. The top 5 executives last year made $33,816,637. You have to ask yourself, again, getting value for the dollar, if we don't do anything about that, then why is this healthcare reform going to work? Now that's just, the top 8 companies paid their executives $9.914 billion in the latest year available. I mean, they made $9.9 billion in profits. They paid their executives over nearly $195 million. So we know that we know that the single-payer systems work in other countries. We know that the money is being wasted in the insurance industry. What we also know is that we can stimulate the economy by going to a Medicare for All system. And the one handout I have is a summary of our economic stimulus study. This, just very briefly, and the reason I mention this is because, again, we want to be able to spend the money in a way that's going to actually not only cover everyone, provide the care they need, but it's going to be good for the economy, because the President's Council on Economic Advisors, which I'm going to talk about in a minute, published on June 2nd how healthcare reform is good for the country. Well, if that is our concern, the best way to stimulate the economy is to put everyone into a single-payer system. For comparative purposes, the Institute for Health and Socioeconomic Policy, affiliated with the CNA and NOC, did a study of Medicare, just putting everyone in Medicare, just for comparison purposes. Everyone would get the benefits that Medicare currently provides, A through D, in the existing system, and which is not as good as Chairman Conyers' bill, HR 676. But even that would create 2.6 million jobs, increase business and public revenues by $317 billion, $100 billion more in employee compensation, $44 billion in new tax revenues. We estimated that you could do that for $63 billion in additional government spending. $63 billion. Now, that's not accounting for all of the administrative cost savings. That's just a straight cash outlay of $63 billion on an annual basis. That is extraordinary. I don't think we got that same rate of return, if I'm not mistaken, on what we paid AIG, Citibank, and Bank of America. I don't think we got 2.6 million jobs out of that $700 billion that we spent bailing out Wall Street. From a fiscally conservative point of view, shouldn't we be spending stimulus money on a social good, a public good that stimulates our economy? Isn't that what it's about? So let's talk about financing options real quick. We know that if we were to have the government cover its own employees through a single-payer system, just at the local level, we've estimated that local governments at the city, county, and state level could save $70 billion by going to single-payer. Well, we've already, so again, from a fiscal conservative point of view, what should we be doing? We should be saving the government money. How do you save the government money at the local level who are experiencing a huge crisis in their budgets in this recession? Single payer. As Healthcare Now is doing a campaign, one of the key activist groups, they call it a win-win. Everyone gets healthcare and local governments save $70 billion. We've gotten a number of local governments in California to support HR 676 on that basis. The specific financing options in HR 676, a progressive excise tax on payroll, ending overpayments to private insurers under Medicare Advantage, increased taxes on top 5% of earners. Those approaches can fund this program. And it can fund it because we know that those dollars will go directly to patient care. How many folks have seen the Citizens for Tax Justice revenue proposals? A very good report that they did earlier this year. They laid out progressive revenue options to fund healthcare reform. They identified, and it's exactly the debate that Dr. Richter talked about. This really, I would urge staff here to engage in this consideration, because it's a fallacy that there aren't straightforward ways on a progressive basis to finance healthcare reform. It is an absolute fallacy. And if we have a debate on the financing options, it's very favorable terrain from a fiscal conservative point of view. So CTJ estimated that you could reduce tax incentives to invest offshore, raise $12 billion. The biggest number comes from expanding the Medicare tax for the rich. Now, what does that mean? That means those of us who are wage earners, we pay Medicare tax, 1.45%. But guess what? Those who earn investment income don't pay that tax. Simply applying that tax to investment income would generate nearly $34 billion. Gee, now that's a radical idea. That actually people who earn money on money should have to pay the same taxes as those who earn money off labor. Oh, wow. My mind. So we could also eliminate other tax subsidies for Wall Street, $15 billion. And we could reduce the tax subsidy for capital gains. Those revenue options in 2012 would generate $100 billion. Now keep in mind, we've identified one approach to healthcare reform as expanding existing Medicare at $63 billion. We've already paid for that and more through those, so we could actually take some of those options away and still cover that. But let's look at that President Council's on Economic Advisors report. His advisors found that key stakeholders agree on a number of approaches to aggressively go after cost control. And what we need to ask ourselves, and the President's own criterion, is what's the best way to achieve what all the stakeholders agree we need to do? It's a fair question, of course, right? Number one, reorienting the financial incentives of providers toward value rather than volume. So, in other words, we're spending about $100 billion a year on diagnostic imaging. Okay? Is that volume or is that value? Well, what we heard earlier in the hearing was, I think it was Dr. Angel made this point, that in fact many of those tests are simply ordered because that's how doctors get paid. And that does not necessarily reflect value. That is, of course, the volume problem that the President wants to address. Let's ask ourselves, what's the best mechanism to address that problem of value versus volume? Is it a multi-payer system where each insurance company is setting its own criteria for reimbursement? Is it a fee-for-service system, right, where, again, insurance companies or doctors or hospitals are competing for doctors and are setting reimbursement rates on their own based upon their own profit or shareholder interests? Or is it a single-payer system that says we're going to negotiate those fees, we're going to provide global budgets to those hospitals and clinics so that the value is emphasized over the volume? It's actually inherent in single-payer that we would reach that objective that the President's advisors had laid out.
Would you repeat that, please?
Well, it's actually inherent in single-payer that we would emphasize value over volume and meet the President's objective. It's inherent in the system, right, as opposed to trying to create a regulatory approach that tries to incentivize or manipulate providers and payers to do the right thing in this case. And we can also take the second one, looking systematically at what works and what doesn't to provide more high-value care. All right, so the President's advisors want us to figure out what provides the best value for our dollar. Again, ask yourself, is the single-payer mechanism preferable in order to be able to do that? And again, we find that it's inherent in the single-payer approach. Because if we're going to look at what works and what doesn't, how best to do that? If we're going to do comparative research, as Dr. Su said earlier this morning, we need an integrated system that is not fragmented and therefore is in the best position to evaluate what works. Thirdly, the advisors want to expand performance measurement and provider feedback. Okay, I think I'll try to convince Aetna and Cigna and United Health to have the same system for provider feedback. Yeah. How would you like to do that? Write a regulation to do that, right? It's virtually impossible to imagine that we could create a regulatory approach that would be efficient in terms of measuring performance and provider feedback. And the same thing is with health IT. Are you going to have one integrated system that's going to be able to actually do electronic medical records and those other ITs in a systematic way, or are you going to actually have proprietary systems that each insurer or hospital uses that can't talk to each other? That really is the question. And all this emphasis on health IT, first of all, it's very expensive. It may not save money. But secondly, it's impossible to do unless you have an integrated system that single payer provides. Same with their goal of reducing fragmentation. They want to do standardized billing. Well, how the heck are you going to do standardized billing if you've got 350 payers? It's virtually impossible. They want to aggressively target fraud and abuse. And again, here's the policy alternative that Congress faces. You can write an elaborate and complex regulatory approach that won't work, that will be very bureaucratic, that will be very heavy-handed, or you can do single payer and have an entity that actually has the ability to write those rules in a way that everyone has to follow them in very clear and simple ways. That's the alternative. And that policy choice has to be taken very seriously, because in the name of political feasibility, we are creating the potential for the heavy hand of government that would far exceed what single payer would do. You're creating an unnecessary level of bureaucracy to precisely avoid what you claim to be government-run health care. It's absurd on its face. Finally, they want to do two things. They want to give patients a greater role. I don't believe that individuals have much clout with Cigna. Now, I could be wrong, but in general, my experience is that it takes a lot of time, a lot of phone calls, and a lot of letters to get Cigna to pay for treatments that they don't want to pay for. And in some cases, as Jerry said this morning, they don't do that unless hundreds of people show up at their offices, and then when they do it, it's too late. And in the case of Natalie Sarkeesian, she died. So it's hard to imagine giving patients a greater role unless you have a publicly accountable system like single payer. It's simply not realistic to think that those who are making the payment decisions based upon the needs of their shareholders are going to be responsive to consumers. It simply doesn't work that way. And finally, they want to reward high-value technology creation that reduces morbidity, mortality, and total spending. Well, I think we know from Dr. Richter that the system that does reduce morbidity is single payer, and that's why those other national systems have adopted it. What we have in the proposals currently before Congress that are mostly on the table, I guess we'd have to say, are those that essentially they're based on two states. They're based on California and Massachusetts. Massachusetts obviously was enacted, the connector system. Well, guess what? Their costs are going from $1.1 billion to $1.3 billion in 2009. And guess where the governor is getting the money to fund the private insurance-based system? Rather than providing the charity care to safety net providers, right, to those clinics who are covering people who need care either on an emergent or chronic basis, rather than funding those providers, they're taking that money and giving it so they can subsidize the purchase of private insurance. Why? Is it increasing value? Is it the fiscally conservative thing to do to give those insurers 20 or 30% of the dollar? It is not. And that is what is perhaps most ironic about these proposals in Congress, that we're going to actually tax American people so that other Americans can buy private health insurance so we can get 69 cents on the dollar in value. That's the proposal. And I know that makes sense someplace. I hope it doesn't make sense in this room. And what's also ironic, of course, is that the connector itself in Massachusetts adds 4 to 5% in costs, in administrative costs. We're taking a simple reform, in this case, they're being rejected, single payer, and substituting an administratively complex reform that adds cost in the very area that's depriving us of the dollars we need for patient care. So, in California, when this type of proposal was put forth, in 2007 and early 2008 with the added addition of a public option, it was rejected. It was rejected by the California State Senate, which had twice passed single payer. Why was it rejected? Because the numbers didn't add up. They couldn't, so the same thing we're facing now. We're told that an agency is going to decide on minimum benefits, right? That's a popular version of healthcare reform being circulated in Congress. We're going to come up with a minimum benefit program. We're going to limit the out-of-pocket expenses by individuals, but those limits may be too high for people to actually afford needed access. We don't know what those minimum benefit standards are going to be. We're going to somehow reform healthcare delivery, but we don't know how, because that's going to be determined later. And then we're going to use IT and best practices to reduce costs, but without quantification of by how much or how. And then we're going to do those subsidies to achieve affordability. Does that make sense when compared to the kind of financing that Dr. Richter and others have laid out that are contained in your bill, Chairman? It simply doesn't make sense on policy grounds. And this is the policy debate that we have to have in Congress. Because a policy debate on the merits is going to do something that Jerry and the other registered nurses around the country know we have to do. And that is to say, we need to pay for patient care first. The first dollar goes to patient care. And that the system that pays for patient care is the system that the American people want, the American people deserve, and that this Congress must enact. Thank you.